Hi, everybody. Welcome to tonight's Woo You event. I'll just give everybody a moment to make their way in. This is a big one, though. We have two presenters, so I want to make sure I give you all the time you need because two of you need a lot of time. So, welcome to tonight's Woo You presentation, Seeing Presbyopia in a New Light, Elevating Care with Contact Lenses, IOLs, Surgery, and Presbyopic Drops with Dr. Melissa Barnett and Dr. Jason Baccarat. That's a lot we're going to get through tonight. I'm your host, Dr. Jennifer Stewart. Thank you to Lens Therapeutics for exhibiting at tonight's event. Please stay tuned for after the CE presentation. There'll be a great presentation from Lens about the great things they're doing. So if this presentation intrigues you and you want to learn more, make sure you stay tuned for a nice presentation after. For each hour of CE, attendees must be online for a minimum of 50 minutes. For a COPE certificate, please fill out the survey link in the chat. The survey link will also appear when the webinar ends. CE certificates will be delivered by email and sent to ARBO with OE tracker numbers. We'll also display a QR code at the end of the event if you have the OE tracker app on your phone. CE certificates will be emailed within 4 weeks, and ask questions throughout using the Zoom on-screen voting panels. You can either use chat or Q&A. If you're on your phone, you can find them here. Okay, Dr. Barnett, you're first. It is my pleasure to once again welcome Dr. Barnett to Woo You. She's a world-renowned key opinion leader recognized for her expertise in dry eye disease, specialty in scleral lenses, keratoconus, and presbyopia. She's authored more than 300 articles and books, delivered over 500 lectures, and is a board member and founding member of the Intrepid Eye Society and serves on several industry boards. She's the author and editor of Specialty Contact Lenses and Contemporary Scleral Lenses Theory and Application, which features insights and contributions from leading international experts. Her work has been featured in medical journals, professional magazines, as well as consumer publications such as The Washington Post, Bloomberg, Prevention Magazine, and Good Housekeeping. She's a certified professional life coach with a focus on mindful leadership, wellness, and public speaking. She empowers individuals to become their best selves in their personal and professional lives. She's energized by her passion for helping people improve their lives by optimizing their vision, health, and wellness with a customized approach. Welcome back to Woo You.
Thank you.
There are her financial disclosures. And now, Dr. Baccarat. He's a glaucoma consultant in Sonoma County, California since 1993. He's the founding partner as well as the medical and research director of North Bay Eye Associates, Inc., which is a multi-subspecialty ophthalmology practice. He completed residency at, how do I say that?
You want it with a Philly accent or Connecticut?
I, my Connecticut accent. You can do it with a Philly accent. I'll let you do a Philly.
Hahnemann.
Thank you. University Eye Physicians and Surgeons in 1992 and fellowship in glaucoma at Jules Stein Eye Institute, UCLA Medical Center in 93. He serves on multiple advisory boards and consults for various ophthalmologic, pharmaceutical, and surgical manufacturers. Academically, he is co-chair of the Department of Glaucoma at California Pacific Medical Center in San Francisco. He's been honored by receiving the Resident Outstanding Teaching Award on 2 occasions. He's a fellow of the American Glaucoma Society and has authored multiple articles on glaucoma management in peer-reviewed literature, including American Journal of Ophthalmology and the Journal of Glaucoma. He's authored text chapters, including one on glaucoma laser management in ophthalmology clinics of North America. He's currently on the editorial board of the American Journal of Ophthalmology, Current Eye Research, and Advanced Ocular Care. He's been a primary investigator in over 200 phase 1 through 4 clinical trials in ophthalmology. He's the past chair of the American Academy's Ophthalmic Knowledge-Based Panel for Glaucoma, serves as a board examiner for the American Board of Ophthalmology, and has been honored with an Achievement Award in 2005 and the Secretariat Award in 2013 from the American Academy of Ophthalmology. So welcome, both of you. I will turn it over to you. I will be back at the end for all of the Q&A that I'm sure we're going to have. Have a great presentation.
Thanks, Jen.
Well, thank you so much for the kind introduction, and thank you all for taking the time tonight to join us on this very exciting topic. And it's such a pleasure to be here with Jason, who's down the street. down the road from me here in California. So thank you to all of you joining us from all over the country, all over the world. We're really happy that you're here tonight. So tonight we're going to be talking about presbyopia, seeing presbyopia in a new light, and we're going to be covering contact lenses, IOLs, surgery, and presbyopia drops.
By the way, the reason that I put Steph Curry on that picture had nothing to do with our Sacramento San Francisco rivalry in basketball, but it had everything to do with his strive for excellence and our strive for excellence in helping our presbyopia patients and not settling, never settling. And that's how he is, and that's how. And I know you're this way. I've listened to you and learned from you, and not settling for it's okay, but always striving for excellence for our patients.
Oh, thank you for explaining that. And yes, we both strive for excellence, as many of us do. We know that presbyopia is inevitable. I never like to use the word old or anything aged or age or anything with my patients. But if you live long enough, you're going to get presbyopia. It affects more people than ever before, 128 million Americans. Almost 2 billion are affected globally, and of interest, about 31 million buy over-the-counter reading glasses. So this is an incredible opportunity, and we're going to be talking about presbyopia in our practices and how we can help our patients. Patients are frustrated by reading glasses. Now, we prepared this lecture prior to yesterday, and yesterday I had a patient, the true story, and I wanted to count the number of times she used the word frustrated. It was no less than 10 that she said how frustrated she was by her presbyopia. And she said this, I'm frustrated, I'm frustrated, I'm frustrated. And yes, presbyopia can be extremely frustrating because it can be the first sign of aging. And in this study, this is looking at 1,000 individuals, those who feel frustrated when I forget to bring my reading glasses to a meeting or a restaurant, 55%. Not having to wear glasses makes me feel more confident, 53%. Wearing glasses makes me look old, 38%. And wearing reading glasses makes me feel less attractive, 34%. So, Jason, in your practice, what do you think? Do your patients come to you with these complaints that they're frustrated by presbyopia?
They do. And it's an interesting evolution in how I handle it, how that conversation goes, uh, echoing exactly what you said. I've definitely evolved from somewhat dismissive to really refining my conversation to be efficient in time, but to explain that there are a lot of ways to manage it.
Do you want to get into that now, or do you want to explain that in a few slides here, how you explain to patients
Well, I mean,
about
really, just
that?
at a high level, I basically categorize it. There's surgical options, there's pharmaceutical options, there's glass options, and they're not mutually exclusive. We own optical shops in our practice, and you can imagine some of the optometric doctors in my group were originally concerned that, if we talked about all of these other manifestations and ways to manage it that could affect our optical business. But in fact, it's increased our optical business because it's not either or. There's a mixing, a blending of treatment options, and uh, I call it mids. And my original saying for mids was minimal installation drop strategy. But really, in this scenario, it's that mindful interaction of drugs and surgery, that opportunity to blend treatment options and work collaboratively with the optometric doctors in my group to find the optimal treatment option for a particular individual.
I love that. And it is a great opportunity for a collaborative approach. How I talk to patients, it's very, very simple, and I do want to share it with you. We have glasses, contact lens, pharmaceutical, and surgical options. And I look at their eyes and say, what? They're drops? There are drops we can use? There are contact lenses I can wear? And then I talk about it like shoes. We have multiple shoes for multiple situations. And yes, you can have a pharmaceutical option for certain situations. You have contact lenses, you can combine them. I think it's super fun. Glasses are essential, sunglasses are essential, and eye health is essential. So we have all these options, and it's really been so much fun. This is a huge opportunity for us. More than one-third of emmetropes don't get regular eye examinations. And eye exams, we know the importance of eye health for everyone, not just presbyopes, not just emmetropes, for kids as well. And this is a great opportunity to educate our patients on the importance of eye health. And that's something that we do in our practice on a day-to-day basis. Presbyopia really impacts your patient's quality of life more than you think. The same patient I brought up earlier, again, not making this up, said, "You know what? When I am in the shower, I cannot see my shampoo bottle." And I said, "I hear you." That's what I said. I understand. That makes a lot of sense. She was pretty emmetropic, tiny bit hyperopic. That makes sense. Now, this is interesting looking at the 1,000 patients. Loss of near vision reported as the primary or secondary most impactful condition. So this is in 60% of patients. And if you look at dry eyes at the bottom, dry eye, which we know is highly prevalent, we have to rule out dry eye in every single patient. Dry eyes affected patients' quality of life in this study 14%. We were talking today about here in our practice about hearing loss and vision. And hearing loss, yes, that affects patients' quality of life, 39% compared to something like high cholesterol, 20%. So let's just move right along here. And Jason, I'm going to turn it over to you.
Great opening. Couldn't agree more with the points you were bringing up. It's just an opportunity to help people. But I'm just going to kind of open this with a couple of thoughts, just kind of random thoughts that I put together that I think about when I'm getting ready to operate or manage a presbyopic patient. And I will tell you that the bar is so high. You all know that. The bar has just gotten ridiculously high on the expectations. I can't tell you how many times the patients come in and they say, "So I'm going to not need glasses after this surgery, right?" And yeah, let's talk about that, Mrs. Smith. So I like to set the expectations before surgery, and it's super important to do that. And it doesn't start with me. It starts with the co-managing optometrist. I love the docs that I work with in my community. We're friends and they get it and they don't over promise. It's super important because you're doomed for failure if you do that. These are paying customers and premium cataract surgery patients, refractive lens exchange, LASIK, phakic IOLs, all of these people. Once somebody reaches into their pocket and it's not an insured situation, the bar goes up. And I know that you all know that. And I think about that when I offer different procedures. Now, cornea-based refractive surgery and postoperative management of these presbyopic patients, the most common thing I hear, my LASIK's wearing off. My LASIK's wearing off, or it worked for a little while and not now. And those patients, that's where that MIDS comes into play really nicely. That mindful interplay between drop strategy and an older surgery, really thinking about the tailoring of how to manage that patient. And it's gotten better, right? And then my post-cataract surgical patients, when I think about them and all of the different IOL types, we've had to hire surgical coordinators to go over in depthly with patients these different options. But ultimately, the decision really rests on me and you and that understanding of what the patient's needs are. And really thinking and managing intensely the perioperative period collaboratively. And we'll get into that a little bit more because I know that Melissa has a lot of thoughts. She's dry eye expert, one of the big issues there. This is an evolving art, this whole utilization of presbyopic drops. We got set back a little bit with pilocarpine, and now we're back in the game with aceclidine. Everybody's super excited. And it's an evolving art. We're starting to see some literature. We have some great pivotal studies that we'll touch upon. And it's becoming a standard of care in our community. But understanding where they fit in from an efficacy standpoint and a safety standpoint is critical, right? Like these drops aren't going to take somebody that's +4 uncorrected with distance and fix their presbyopic problem. So understanding the pharmacology is critically important. And finally, I would end with understanding the safety concerns and making sure that we do a good job. So a lot of things we're going to try to touch on in this talk here, and I'm going to turn it back over to Melissa with a question. And that question to you is, how do you think about co-managing these patients? You work with amazing cataract refractive surgeons at UC Davis and in your community. What's it like on your side?
Well, I think the most important thing is setting the expectations. Setting expectations prior to a dry eye treatment, prior to contact lenses, prior to anything is really important. So it's setting the expectations and having the good communication. And I find that communication is key. So I communicate with many surgeons differently. Some I communicate on the phone, some I communicate directly, some I send a message. It's having the people that you trust and having the conversations and which are very helpful. Like I know that some surgeons do these procedures and others do those procedures. So to answer your question, when it comes to surgery, I have a wonderful network of surgeons that I work with. And since I've been practicing for a while now, it's great that I know who does what and comfort levels. And just like they know our comfort levels too. So I think it's just a great opportunity to work together. And of course, having the conversation with the patient, including the patient in the conversation, because it's all about the patient. We want to have best practices for our patients.
And again, as Melissa elegantly started this is just a great opportunity. This changing paradigm, builds practices and it's good business. It's not bad business. It's good business. Many cash pay patients, uh, happy people that are looking for a different way to manage their presbyopia and vision. And as we touched upon, turning that frustration to happiness. And it's just such a cool thing. Melissa gave a great anecdote. I had an anecdote last week, a 58-year-old anesthesiologist that I used extended depth of focus lenses on. He was a myope prior to the surgery, and he just wasn't happy with his near vision. He's looking at EKG machines and different very important printouts while he has my patients under anesthesia. He was super unhappy, and he made me unhappy, because the surgery technically went great. I did a wonderful pre-surgical conversation saying, look, this is different than being -6. And he was still unhappy. And I sent him for a second opinion to one of my partners. We talked about lens exchange. He hugged me when he used some aceclidine in his eyes. He literally hugged me the other day. He was so happy I thought he was going to cry. 58-year-old grown man. It was so cool. So, um, win-win scenarios are always good. These people are, it's not just pickleball. They're looking at stock market readouts on their iPhones. They're living life, and whatever we can do to help them. It's a great challenge for us in the office.
I think it's a great challenge. It's also a great opportunity. And I really enjoy helping people in these different ways. And it's different for everyone. And just presenting all these options and seeing how we can be creative and really getting to know our patients. What do they like to do? What do they like to do for fun? What do they do for work? How is the lighting situation also? Radiologists come to mind working in a dark room. Are people working in dim light and or are they outside? Having these conversations and offering these technologies and offering these pharmaceutical options, it's just been so much fun. And it's just a great opportunity. I've gotten so many referrals, which is amazing. And I love making people happy. So tell us
This
about
lady, this lady, you're not going to make happy. We all
this.
have these people, but That conversation that you're talking about between the referring doctor and the surgeon, this can be really helpful. And, we all have these patients. If you give a prompt there, Melissa, insights from that managing doctor, this is the one where I want the phone call,
Yes.
not just like she's particular. Uh, and you touched on it. I'm so glad you touched on it, managing that ocular surface disease. 20 years ago, I would have just operated on a patient like this and, standard monofocal lens, no issue. Now with these new lenses, managing that OSD is so key. And getting insights from staff and co-managing doctors is key. Always diagnostic testing. How you manage that, are you going to do the OCT? Is the surgeon going to do the OCT? Don't both do it. Work together. Uh, Question on RD, we promise we will get to that. Thankfully, that number is going to be really, really low, if not zero, if we're good doctors, but we'll get to that.
Mhm.
And then informed consent. Informed consent does not mean that piece of paper that people sign. It does not mean that. Informed consent starts with the conversation in the optometric doctor's office, and it continues through the perioperative period. Perioperatively, encouragement. Stay positive. A lot of times I love to bring the optometric colleague in early if somebody's kind of iffy. And I really try to shorten that inter-eye surgical lapse, particularly if there's going to be some anesometropia between eyes or a premium lens implant. Diagnostic testing when appropriate in the perioperative period. You might not need it there, but you want to think about it, looking for CME, some issue that in they're, they were aiming for Plano and they're a +2 hyperote. Maybe they have CME at 2050 instead of what should be 2020. And then finally, postoperatively, this is where those new adjunctive treatments, the glass is old school, obviously. Patients aren't going to be happy if they paid $5, $6, $7,000. And the first thing you come in with is, well, maybe you need some glasses, even though you talked about it. So pharmacotherapy, maybe a contact lens temporarily. I usually leave that to my optometric colleague to help me with these decisions. Managing OSD all the way through, super important. And diagnostic testing when appropriate. If all else isn't working, maybe you do need to look at that macula, see if there was a little ERM that was missed.
And I think that we've all learned this over time, but just for those of us as a refresher, managing ocular surface disease, I learned this many, many years ago when I referred a patient for cataract surgery, and then the patient was sent back to me because I did not manage the ocular surface well enough. And that one patient taught me the importance. So this is prior to any type of surgery. It could be cataract surgery. In my mind, all cataract surgery is refractive cataract surgery because of all the options we have. It could be refractive surgery, it could be glaucoma surgery, it could be retina surgery. We always have to manage that outer surface. But we do have this wonderful opportunity to help our patients. And when we're talking about corneal refractive surgery and this LASIK wearing off, I love that because we hear that. How do you respond when a patient comes in and says, my LASIK is wearing off?
Yeah, first of all, I never throw another surgeon under the bus, right? I always say, look, your surgeon did a great job. This is a natural process in your eye. And, we have to manage this in just like you had to manage it before when you were myopic or hyperopic. Really, myopic LASIK was much better. But now it doesn't have to be with glasses or with an unusual contact lens fit over sometimes a steep cornea or an irregular cornea. And I love the fact that I can manage this, particularly spherical aberrations that may be amplified by a large pupil using pharmacotherapy. And as all of you know, I'm not going to try to talk optics to this. By the way, we had 1,000 people right now. There's 1,000 people listening in, Melissa. So congratulations to Lens and Wu University. That's just, super impressive. And this shows it's such a hot topic. But, spherical aberration is obviously an optical defect where, your peripheral light rays coming through the lens, accentuated by a dilated pupil, are going to create a blur for the patient. And any way to mitigate that through meiosis can be really, really beneficial. And of course, you're also going to have an improved depth of focus, just like a lens implant, an extended depth of focus lens implant. This can be a lifesaver now to have this available to us in helping avoid potentially a risky surgical procedure. Eyes that had RK can be challenging with cataract surgery. Those RK cuts can open up. You can get into all kinds of problems with inducing irregular astigmatism. So I love this option. There's also an occasional case where docking from a LASIK machine, remember, it raises the pressure a lot. There's cases in the literature where people have had uh, uh, chronically dilated pupils from arterial occlusions, ciliary artery occlusions, and get a tonic large pupil. And this may give us, an excellent option for those people.
And the one thing that I really like is that it's a temporary option. When we're talking about a pharmaceutical option for presbyopia, it's temporary. It's going to wear off. We can try it out. We can see. And of course, we're going to get into good candidates and all that, but it's not a surgical option. So it's always nice to have these different options and we can offer them to our patients.
And that is perfect for this guy right here. You nailed it. This is a retinal surgeon who drove far for me to do his cataract surgery. And he already had LASIK surgery on the eye. He wanted distance vision. He wanted everything done. He wanted the floaters removed. And so it was a post-op LASIK. I didn't have his pre-op LASIK refraction, although he seemed to know it. He seemed to know a lot. When I walked into the room, I knew I was in trouble. He was refracting himself. And I didn't know retina surgeons could refract. And, I asked him, what are you trying to achieve? Like, what do you really want? I want to try to make you happy here. So, you got to look, you said it, you got to look at each patient individually and see what they are really striving for. And we're going to talk about some of those options in a second.
So what was he trying to achieve?
Make me crazy. He was absolutely
Okay.
trying to make me crazy.
Was he successful?
Yes, he was happy in the end. We went for monovision, and he actually had for like 4 procedures. Like he's happy. He's a great guy. I'm embellishing a bit, but he's a great guy. So when we talk about options, this is a really cool option. Melissa, you talked about reversibility. A corneal inlay is a reversible treatment option where non-dominant eye, you could create a monovision with one of these inlays and use the dominant eye for distance and have, either a mini or full monovision situation. There's no peer-reviewed literature on combining this with miotics, but theoretically, at least in some of the early studies, it does have some perceived benefits in contrast sensitivity in mesopic situations. Not perfect, no free lunch surgically. There's no free lunch. You go in there and you try to remove this thing, you can be left with some scarring in that cornea, some stromal scarring. And and so this is not a perfect procedure, but it's an option. And surgeons that use this regularly love this instead of a LASIK surgery or let's say a secondary ACIOL. So another way to create pinhole optics. And this is that patient we talked about earlier. I think, we don't need to go through this again, that rejuvenating that post-operative refractive patient, just understanding that if you have somebody that's had LASIK or had PRK and they feel that it's wearing off because they're presbyopic, instituting meiosis can be just enough. And, you might want to try it in a monovision situation. Have you used um, any of the miotics in one eye in any of your patients yet?
I have used mostly it's two eyes, I think. Yeah. And have you tried it in one eye? It's an
I
interesting
have.
thought.
Actually, one of our technicians is using it in one eye, and it's working fine. She likes it, but I'm with you. Even in a patient like this, I would suggest binocular treatment. And the reason is you don't give up near vision with aceclidine in particular. When you look at the results of the clinical study, 41% of people had improved distance vision. So, I'm like you, I've been using it, has been using it monocularly successfully.
Oh, very interesting.
We'll
See,
learn
I'm always
more.
learning.
Yeah, we'll learn more.
Yes.
Now we'll get into IOL technologies. And Melissa, I know you co-manage a lot of these patients. There's a lot of different treatment options, as you see listed here. But there's crazy people out there, like this guy, he was an engineer, right? And he's a great guy, but I operate on his left eye. He was he was like a mild myope. And I operated on his left eye. And said, I want distance vision. And he had a little bit of pucker, so I didn't use a multifocal lens implant. I used a monofocal lens. I nailed it. It was like 2020. And he's like, I hate this. Don't operate on my other eye. I miss my myopia. And in fact, you see he dremeled out the glass. He literally dremeled out the glass. I've never seen anything like this. I'm like, dude, I need to take a picture of you and I need you to sign a HIPAA compliance statement so I can show it to my friends.
That's amazing. I've never seen anything like that.
So what kind of options out there? I don't use a lot of sulcus-based implants. Even though, I'm a glaucoma specialist, so I'm always worried about things in the sulcus, meaning behind the iris and in front of the capsular bag in that space. But there are certain situations where, if you have somebody that's like microspherophakia, a super high hyperope, somebody that has a lot of astigmatism, and the lens implant choices that are available commercially don't get you there. Well, you could add this in. You could add this in for presbyopia, and many surgeons do. I've been reticent to go into the sulcus a lot. If I was going to do this, I definitely would do lens capture in the bag. So I'd put the haptics in the sulcus, but I would put the optic into the bag. I wouldn't want to leave it there because I always worry about UGG syndrome, where they can get hyphemas or elevated pressure, almost like a pigment dispersion. It really is a pigment dispersion from rubbing of the iris on these secondary lens implants. So not my favorite thing. I'm being nice. Informed consent. Do you have you seen those in practice?
I maybe one or two, like
Yeah.
very, very rare.
It's not in
Yeah.
our area here. There's not a lot of surgeons doing it. Down in San Jose, there is. So there's a lot of regionality to these things. Small aperture IOLs, what a interesting idea. Very much like pharmacotherapy. So this would be a great idea. Melissa brought it up. If you were considering suggesting a small spherical aperture IOL to a patient, you might want to try pharmacotherapy first to see if it makes sense. And here, what you see is a lens implant that it improves or extends depth of focus by filtering out peripheral light rays. And this works really well if you have a patient, for example, that has some irregularity of their cornea and you weren't uh, able to do a corneal procedure. It filters out some astigmatism, right? Just like a pinhole aperture would. And so it has useful applications for certain individuals, post-refractive surgery patients, anybody with an irregular cornea. This is in the toolbox. It's a relatively new lens into the market, but this is in the toolbox for people with irregular corneas, irregular astigmatism, and you're trying to create some benefits for near vision or irregular astigmatism.
And cosmetically, do you feel that patients are affected by the small aperture IOL?
Yeah, well, here it's accentuated because in the picture, this patient's dilated, but in the pupil's natural state, it's not as bad. What happens with these IOLs, though, is there is a risk. You got to tell patients they can have some dimming of the vision, just like you have to explain to people with pharmacotherapy when they first start a presbyopic pharmacologic drop that they may have initially. some dimming of the vision till their photoreceptors get used to this, which happens. They photo adapt for sure, but in the beginning, that would be a warning you want to give the patient. I should let you talk about monovision. You know so much about monovision. I'll just open it with, there's a lot of different ways to do monovision now. You can use an LAL. You could lock in. You could get somebody that you want to really refine it post mini mono. Because if I'm off and I go for full mono, I'm always worried that the patient's not going to accept it. So I undersell and I try to overperform here. And what's really cool with mini mono now, if the patient's not 100% happy with their near eye, you can add in a pharmacotherapy to get them where they need to be. And I'm going to turn it over to you on this because I know you manage a lot
Yeah,
of these people.
I do. Yeah, that would be a great option to use it in that non-dominant eye pharmacologic option. So I will say about monovision, I love prior to surgery is trying monovision with contact lenses. And the timing of that is such where you want to try the monovision with a contact lens prior to visually significant cataracts. So it can be a little bit tricky, but even if they have visually significant cataracts, it does give an idea. And I look forward, there's no published literature on using miotics, but I look forward to that. That's going to be really fun to see we have so many different options for
I'm sure that
publication.
I'm sure that all of these people on the line are thinking about all the different applications in their practice too. Oh, it's really cool. We're all learning this together.
We are. It is really cool.
Just a point on premium lens implants. That's really not the goal of tonight's conversation, but making sure that you're using premium lens implants and suggesting it to the right individual. If somebody has pathology in their retina, you should not be suggesting a multifocal lens implant to them. If somebody has manifest glaucoma, you should not be suggesting a multifocal lens implant. An extended depth of focus lens, it's a safer option, and you don't have to worry about a patient's retinal pathology or optic nerve disease to an extent. To an extent, there are some surgeons that are conservative and understandably so, and they won't even use an EDOF lens in that group of individuals. With an extended depth of focus lens, a lot of times you don't get them all the way there for near. And like the anesthesiologists I talked to you about earlier, that's a great place for pharmacotherapy. Bringing that in to get them where they need to be up close and making the patient happy, but without doing something that's risky. So remember, multifocals, clean eyes, no retinal pathology, no glaucoma. They haven't undergone refractive surgery. Some of my colleagues will disagree with that last one. Some refractive surgeons, they say, no, you can still put a multifocal in, but you got a lot of layers of potential for dysphotopsias and other refractive issues with an altered cornea and then a multifocal IOL in the bag. So I stay away from that.
Yeah, so let's talk about meiotics in the pseudophakic patient. So this was looking at a study from Lens, and the really nice thing about this study that I like is that there are all types of patients that are included in the study. So all different ages and races and ethnicities, pupil sizes, iris colors, those who have had refractive surgery and those who have had cataract surgery in with monofocal lenses. So it's really nice when we have this large type of patient population because that's what we're seeing. We're seeing a variety of patients. So this specifically is looking at those in pseudophakic patients and looking at the starting distance corrected near visual acuity. So having distance vision corrected, checking the near vision, and looking here at the improvement in vision. So 40% of patients were 20/80 or worse, and more than 80% of patients were 20/63 or worse. And again, this is all different types of patients with different conditions. So, question for you, in your experience, can you use miotics to get a post-op pseudophakic patient to 20 happy? Because 20 happy is more important than 2020, right?
And the answer to that question is it depends. Just
Sure.
like everything else. When my wife asks me a question, that is my stock answer. It depends. So, can you use a meiotic to get somebody to 20 happy after surgery? You're right. We ran the studies for seclidine, for Viz. We ran the studies for both pilocarpine approved products, and we ran the studies for other IP that's coming to market. And what I like about the aceclidine study is we included patients that had monofocal IOLs set for distance. And we included people that had prior refractive surgery. They were invited to participate in the study. So they could have had LASIK, they could have had a cataract surgery. And your point is absolutely spot on that these people did just as well as the general population that were invited into the study. So if a patient needs more presbyopic correction, yes. If a patient complains of glare and halo, yes. If there's undiagnosed pathology, ERM, glaucoma, ARMD, no, drop's not going to fix that. And again, the take home here is we have data. We have data in a well-controlled clinical trial with a very large number of people that was looked at in a prospective, blinded fashion by investigators. And your point's spot on.
So I think we've talked about all these surgical options. You did a wonderful job there. And let's look at some of the FDA primary and secondary endpoints. So this is set by the FDA, which is a greater than or equal to 3 line, so 15-letter improvement in, again, that distance corrected near visual acuity. Just a gentle reminder to be checking near visual acuity in all of our patients. There was no loss of distance corrected acuity, and that's what we're seeing in clinic too. So I love how in clinical practice with aceclidine, we're seeing improvement in distance vision as well as near vision. And this is looking in monocular one eye and binocular acuity reporting. Secondary endpoints were greater than or equal to 2 line improvement in the distance corrected near visual acuity, and those achieving 20/40 or better. So let's talk about some safety considerations because wow, Jason, you've done all the studies. That's amazing. And I'm sure that you're well aware that not all meiotics are the same. So tell us about the differences and when we should have caution, because of course we want to be very safe when we're managing our patients.
Yeah, I mean, let's do this smart, right? Our initial experience with meiotics in presbyopia started with pilocarpine, and pilocarpine is something I grew up with. I'm a glaucoma specialist. I'm an OG too, right? I'm an old guy, and so I
Are you
use
an
pilo.
OGG? Are you like an OG glaucoma?
Don't tell Jamie Brandt that. Don't tell
Okay.
Jamie. Jamie Brandt is a great friend and a glaucoma specialist that works with Melissa up at UC
He's an
Davis, and
OGG also.
we're OGGs. Um, so it's a good glaucoma drop, as you all know, other than its side effect profiles and the fact you have to use a QID, but it works. And the difference is that it's not a great drop for presbyopia. And the reason is that not all meiotics are the same. Some meiotics are more selective for the M receptors in the ciliary body, i.e., pilo, and that's why it works to open the drain pathway, the conventional outflow system. And it also induces myopia because it moves the lens iris diaphragm forward and it causes a more globular shape to the natural lens. And that's why it blurs your distance vision when you use pilocarpine. Uh, and so it's not a perfect meiotic for presbyopia. And in fact, it doesn't bring the pupil down as much. We learned that in clinical studies as aceclidine. Aceclidine, on the other hand, is a terrible glaucoma product. It used to be a glaucoma pharmaceutical. It was a much higher concentration and never made it here in the United States. And it's been off the market in Europe because it just wasn't a good product. But two brilliant doctors, one that I was friends with, Lee Nordan, cornea specialist in San Diego, who unfortunately 10 years ago, at the prime of his career, passed on from a glioblastoma, and Jerry Horn, who's an excellent ophthalmologist in Chicago, looked for a molecule for presbyopia and found aceclidine, and they're brilliant guys, and entrepreneurs, and they did all of that initial legwork to bring aceclidine to market. Uh, so some other miotics can induce cataract, phospholine iodide. Those that handle kids with squint know that. We wouldn't want to use that here. And all of the drops, including aceclidine, can have mild headache, usually associated temporary, some drop irritation, and some redness, and some dimming of vision. And these are the things that I go over with patients, that last side effect profile, every single patient that I start. And if you go over with it up front, you're going to reduce the callbacks to the office, and you're doing the right thing by your patient by being upfront with them. So I tell every patient about these issues. I tell them they can use a little bit of vasoconstrictor in their eye, which works great for the redness. And the dimming is usually transient as well. So how about you? How do you handle this?
Yes, and I think we're all learning this together. And yes, I go over the side effects with every single patient. So I say there are no systemic side effects. There can be some headache, some eye irritation, some redness, some dimming that typically gets better in 3 to 5 days. And that's been my clinical experience in the studies. These were all mild. And so that's always nice that the headache, the drop, installation, irritation, redness, and dimming were mild that do tend to improve over time. And I've seen that in clinical practice as well. But I think it's really important, as you mentioned, to have the conversation because we can't just prescribe and let our patient go off and say, oh, I put in this drop and my eyes were red. I had some dimming. You didn't tell me about that. So it all goes back to setting those realistic expectations. And I also really like to communicate with my patients whenever there's anything new. But now that we have this new pharmaceutical option, it's communicating, it's talking to them and asking them, what do you think? I love feedback from my patients. Like, what do you think about this? And is this something that is helping you? And I love the patient feedback and they're excited. And I tell them, this is new and I would love your feedback. And I would love that. And that really helps me for other people as well. So we're getting to that question that was asked earlier. Thank you about the retinal detachment. So in the general population, 25.3, and this is per 100,000 person lives in myopes. So, and this is the question I've been dying to ask you, Jason, about the level of myopia here that you'll prescribe. And this is -6, as you can see, the rate of retinal detachment, 67.5%. And then those who are high myopes, more than -6, it just increases tremendously. So the question I think that everyone wants to know is when are you going to prescribe a miotic? Will you prescribe a miotic for certain refractive errors? And if those who say had LASIK or some sort of corneal refractive surgery, and it's not exactly known what their pre-op refractive error was, how do you make that decision?
Yeah. Great questions. I don't want to get too wonky right now on this, but I will tell you that in the clinical study, it was -1 to +4, as you showed, spherical equivalent. And if a patient had surgery prior, LASIK, or they were pseudophakic, and we did not know their preoperative refraction, we looked at their axial length. And if their axial length was longer than 22.4, which is not a long eye, if it was longer than 22.4, they could not be in the study because we wanted to, really reduce the risk in a clinical study. But I'll tell you, in the real world, that anesthesiologist I just talked to you about, he was a high axial myope. I sent him to a retina specialist. I just operated on him. So he was already at a higher risk for having a tear, which could turn into an RD. And then, I was concerned. So if you're concerned and you're not comfortable doing a dilated retinal examination, send them to a doc that is and let them take a look. I'm not a good scleral depressor. It's not my thing, and I look with a 90 and look at the retina with a 90. But if you're not sure, send it to somebody that is. What we don't want is like, you know, people going crazy here and utilizing these drugs in without a clinical examination, because we don't want bad things to happen and then we lose access to this. So do a dilated examination. Somebody on one of these drugs is going to have an RD. That doesn't mean the drug caused it, but the patient might attribute it to that. And so I think it's important to just do a good examination.
And
That's
I
my
tell my
feeling.
patients that I will not prescribe without doing a retinal examination. So if there's lattice, if there's holes, if they're high myope, no, they're just not a good candidate for this option. These are your
Well,
final thoughts.
well,
And
first of
then,
all, it was really hard for me to find a picture with my old presbyopic glasses. And the only one I could find is with this guy. I don't know who this guy is that's in this trying to hog the picture with me here. My good friend Paul Singh. But, you know, consent, collaboration, what a great addition to the toolbox, everything that we talked about tonight. And supplementing surgery, MIDS, mindful interaction of drugs and surgery. It's happening in every space: glaucoma, macular degeneration, now presbyopia, um, dry eye, procedural based dry eye and drop therapy. It's not one or the other. And don't be immune to these patients. You opened fantastic here, Melissa, when you talked about the opportunity and the just incredible numbers that you shared with us. We're all going to be there, right? Like I'm pseudophakic. I'm plano and -50. Luckily, I had a clean cataract surgery by one of my partners, did a great job. But, I'm pretty athletic guy still. I like to not have to bring my reading glasses with me, and I still have my iPhone when I'm on my bike or whatever. And I'll use the Viz, which is the branded name of aceclidine, and it works really well for me. I don't use it every day, but there are many days where I just enjoy that added oomph that it gives me. And it works so quickly, I don't need to have a reorientation of my brain to have it work. And that's important. Remember, with some of the other drops, there was that whole story that we had to give, use it for 2 weeks every day for it to have its effect. We don't need to do that now.
yes, and we have a few more minutes, and we have a few more slides here. I know there's like so much to talking about options for patients. We want the ability to the duration of action. We want to see how the patient's lifestyle, do they want something that wears off in 4 hours? Do they want something that wears off in 8 to 10 hours? And also going over those side effects. Now, I'm going to just touch on contact lenses because contact lenses are just so much fun. And when we're talking about miotics and contact lenses together, but it's great that we do have solutions now. So we have fast acting, we have long lasting, we have reversible options. And many of my patients want that spectacle independence. So they want to be free of glasses. We talked about the small aperture optics, which are really helpful. And I'm going to skip over here just a few slides. But this is a super, super exciting time in presbyopia because we have three FDA approved options that are pharmaceutical options for presbyopia. And think about this market. So if only 5% of presbyopes utilize presbyopia drops, the market is about 3 times larger than the dry eye market. And so that's why I bring it up to patients. We have glasses, we have contact lenses, we have pharmaceutical, and we have surgical options for presbyopia. And what are you interested in? So the contact lens options are really fun because we can combine them. For example, a soft toric lens for distance with a miotic, we can use multifocal, soft multifocal, or a scleral lens with a miotic. And here you can see this exciting space that we're in. So we have all of these different options, 3 FDA approved, a few more that are coming in the future. And I always think that we're just going to lift each other up and bring awareness, which is great, bringing awareness for our patients and helping our patients improve their lives because we have all these options. So it's really nice that we have different lens options, and the newest here is aceclidine, which is a selective cholinergic muscarinic receptor miotic, as Jason mentioned. And so this works differently than the pilocarpine options that we've had previously. We talked about the importance of a dilation. And I'm just going to end here and then leave it to any questions that might come up. But this is a great opportunity. Having pharmaceutical options for presbyopia is a great opportunity to complement contact lens options. So whatever your patient is doing, it just great. So say they're wearing a contact lens for distance. I bring up these miotics that we have this option that can help, and they don't have to use them all the time. So I can think of many patients that I have, and we have the conversation when they're at work, when they're bike riding, when they're hiking, when they're out, whatever it might be in their lives, that it is an option to use in addition to contact lenses. It's also an option to use at other times. And the contact lens market is growing. I'm very thrilled about this. So the global contact lens market is growing up to 18.3 billion in 2032 from 11.08 billion in 2024. This is a compound annual growth rate of 6.5%. So we have options, and I'm just going to go way to the end here. The keys are lighting situations, preparing those pre-presbyopes. I like to talk to 20-year-olds about presbyopia and why their parents are presbyopic. And we have this great option to give our patients the spectacle independence. So whether that's a pharmaceutical option, whether that's a contact lens option, surgical, glasses, combination, here you can see some of the quotes, and these are from real people. It would offer me freedom to enjoy myself without limitations. It would be really nice not to wear glasses, not to feel old. And this is also what we see in clinical practice. And I'm going to answer, thank you for asking the question. Why not use a multifocal contact lens instead of a pharmaceutical and contact lens? Um, it depends. So, right. So we can use a multifocal contact lens. Say that a person is not happy all the time with their multifocal lens. In certain situations of their life, they would like to see better. That would be an option to add a miotic and try it out. Say it's a certain circumstance where they want to see up close. So it's really goes right back to the patient. And that's what's so great is that we can really customize our care now for each individual patient. So we can use one or the other or both in combination. And we have another question here. Are we able to prescribe the drops if there is retinal pathology? And I'm assuming we're talking about pharmaceutical options for presbyopia here. So I gave my answer about retinal pathology, such as lattice, or if there are holes or tears. I'm not going to prescribe the drops. Jason, what is your answer here?
Agree 1,000%. Yeah, don't do it. Why? It's something that it adds risk. Our partners in industry that make these medicines, they don't want us to do it. So there's no reason to take that risk for an individual. And if you, for some unusual reason, you felt like you had to, and that was the only option, send them to a retina specialist, because if there's any areas of lattice that look iffy, they might want to do some tack down laser before you institute a drop therapy. So again, heed caution and use it wisely. There's so much low-hanging fruit out there.
Well, thank you both. I know there are so many questions that keep popping up, and I think we need a full extra hour to get to them all. But thank you. This was a wonderful presentation. I always enjoy having two people because I think the conversation and tag teaming makes it even more interesting and really gives a sense of how you both do things similar and different. So thank you both for your wonderful presentations and your great clinical pearls. For all of you that we left hanging in the chat and Q&A, there is a great opportunity to ask those questions again and have them answered in the next room. So make sure you click that link in the chat box. The QR code is coming, so don't leave yet. But thank you to Lens for exhibiting at tonight's event and ask those questions in the next room. This is your opportunity to ask those questions about aceclidine and ask all of the questions we didn't get a chance to answer. I know there were so many, so make sure you join us over in the next room for that. And with that, there are some directions on how to get over there if you haven't done that yet.